Great. As Dr. Stern had mentioned in the video, we would like to take a moment to thank all of our donors that have supported the research projects that will be presented in this group tonight. As we introduce each student, we will also be recognizing each of the donors' names that have supported the project. Also, to reiterate, there will be 5 minutes for questions at the end of each presentation. Please hold all of your questions until that time. When it is time to do questions and answers, please feel free to unmute yourself or type something into the chat box. Both myself and Dr. Steinberg will be monitoring the chat box. So let's begin. Our first student, Alexandra Caleri, is up, and her project has been supported by the Charlotte E. Zand Memorial Endowed Research Stipend, supported by Dale E. Zand, PhD. Alexandra, go ahead.
Thank you. So I'm just sharing my screen here. All right. Okay, so our team set out to study the influence of patient sex on pain control and multimodal analgesia in TKA, or total knee arthroplasty. So postoperative pain following TKA is typically treated using a standardized multimodal analgesic regimen that's given to all patients regardless of sex. But there are 2 problems. The first is that many of these pain protocols incorporate opioids for pain control. Pregabalin has been briefly explored as an opioid-sparing addition to multimodal regimens, but there's very little data on its use and its ability to reduce post-op pain in the context of TKA specifically. The second problem is that some of these studies have suggested that there may be a genetic predisposition to pain, and even that females are more likely than males to report higher pain scores both before and after surgery. Again, these differences haven't been explored much in the context of TKA. So our team wanted to take a deeper look at both of these problems. First, are there differences in pain perception between male and female patients following TKA? And second, can pregabalin effectively reduce post-TKA pain and ultimately opioid consumption? So to do this, we prospectively recruited 150 patients between the ages of 18 and 80 who underwent TKA at 6 different hospitals within Northwell. We first grouped them by sex in order to compare male versus female post-op pain scores. And this pain was measured using patient-reported VAS pain scores, the knee injury and osteoarthritis outcome score, or KOOS, and for how long post-operatively patients were taking oxycodone. Then the male and female cohorts were randomized into groups either receiving pregabalin as part of their pain regimen and those not receiving pregabalin. And then the difference between pain scores in those groups were also analyzed. So what did we find? First, female patients reported significantly higher VAS pain scores at almost all post-TKA time points, both at rest and with walking. So figure 1 on the left shows the differences in pain scores while at rest. And we can see that at all time points after surgery listed on the x-axis, with the exception of the last 26-week mark, female patients reported significantly higher pain scores than male patients. On the right, in figure 2, looking at pain with walking, we see the same thing, significantly higher scores from female patients at all time points except for the last. And as you can see, majority of these time points showed a p-value of less than 0.001. So these results are very significant. Second, we found that more female than male patients opted for opioid use at each post-op time point and were ultimately taking opioids for longer after surgery. However, these differences were not statistically significant. And lastly, we did not find that pregabalin significantly reduced pain scores at rest, nor with walking up to 1 week post-TKA. This branch of the study was actually ended early since no significant differences in scores were appreciated up to a week post-op. So why do these findings matter? Clearly, we're seeing females reporting higher pain scores post-operatively and trending towards higher opioid consumption. And this gives us strong reason to believe that perioperative pain management protocols should no longer be standardized one-size-fits-all protocols, but rather that we should be working towards creating a personalized protocol for male and female patients that reflects the differences in their reported pain, as demonstrated in our study. And while our study suggests that pregabalin may not be the best analgesic agent in reducing post-op pain scores, more research is needed both on pregabalin itself, as well as other alternatives that we can incorporate into these pain regimens. And a huge part of our goal as a healthcare team is to help patients rehabilitate sooner and get them back to the activities that they were enjoying before surgery. And if our pain management protocols are not adequately addressing the needs of our female patients, especially, this is setting a big roadblock to recovery for a significant portion of our patient population. And these findings go beyond just orthopedics. Yes, we're looking at TKA data, but when taken in conjunction with the studies that are already out there showing high pain perception in female patients, this is really an issue that impacts all branches of medicine and should even prompt us to reevaluate our stereotypes of female pain tolerance. The reality is that the data is showing females perceiving more pain than male patients, and our care management needs to reflect that. Thank you.
Thank you. So now we'll open it up to 5 minutes of questions. As I mentioned before, if you have any questions, please feel free to unmute yourself or put something into the chat box.
So I have a question.
Yes.
Do you think that the difference in pain is a real difference in pain levels, or is it a cultural thing where males deny their pain because males are supposed to be big and strong and tough and not admit that they're in pain?
Yeah, that's definitely a great question. And I think that especially when it comes to pain studies, it's so hard to say because pain itself is subjective and there's limited ways that we can evaluate it. So, in our study, the VAS pain scores and the KOOS scores, they're all patient-reported numbers. I guess the more objective way that we evaluated it was how often or for how long after surgery they opted to take oxycodone. But no, I definitely see what you're saying. And I think pain itself is so multifactorial. There's so many things that can go into it, as you said, our societal norms. And that kind of goes both ways. You can think about, the preconceptions that we have about females and how much pain they can tolerate. So I think like the stereotype that exists right now is, females, they have to go through giving birth, they menstruate every month, so they must be going through so much pain and used to tolerating this pain. But that ultimately is not, a good reflector of what is actually going on inside. And I guess, studies are showing that they genetically can be predisposed, to actually feeling and experiencing more pain. To add on to that, also another factor that could be unaccounted for is the fact that they could be, opting to take these pain medications prophylactically because they're expecting to feel more pain. So there's certain things that it's harder to control for, but you're definitely right in saying that there's so many factors, including social ones and psychological ones that kind of go in when we choose how to evaluate pain.
And we have 2 other questions.
We'll go ahead with Mark, please.
Hi, thanks for your presentation. Kind of a nitpicky question about the pain scale that you use, because you're describing it as a visual analog pain scale, but it looks like the way you've got it at least shown on the y-axis is as a numerical rating scale from 0 to 10, a Likert scale. Which did you actually use? I mean, they correlate very well with each other. I'm just curious as to which one you used.
The Likert scale, 0 to 10.
Yeah, so you shouldn't call that a visual analog pain scale. That's it's a different scale. Visual analog pain scale, you draw a line across, and say your pain is this point along the line, as opposed to saying, what number is your pain score.
Okay, thank you.
Debbie, go ahead.
Yes, thank you for this presentation. 2 questions. Did you also look at all about weight as an issue in terms of pain management? Did you look at that variable at all? And also, how far back? What time period were these? Were the records taken from? I was surprised it's all oxycodone, not given all that's gone in the media and everything.
Right, so to address your first question, weight was collected as one of the demographic factors in our study. It wasn't reflected here in the data. There were a lot of sub-analyses that were conducted. I personally don't have access to that analysis. What you see here is what I have right now, but I do know that it was collected and it was something that our team looked at in their analysis. And regarding the time frame, I'll be honest, I'm not sure when the first analysis or the first patient chart starts, or the earliest one rather, but I think they come up to 2020.
Thank you.
I had a question as well, Alexa.
Yes.
I was wondering if you could expand upon why looking at alternatives for opioids is important, specifically in the context of orthopedics.
Yeah, so as we all know, the opioid epidemic is huge and ongoing and has cost our country a significant amount of money. And I believe back in 2015, it cost us almost $1.02 trillion. And the deaths related to opioid use are increasing still. Specifically in the context of orthopedics, and this is something that I kind of found out as I was doing some background research for our study, orthopedic surgeons actually contribute to almost 8% of all opioid prescriptions in the United States. And so clearly we have a huge role in this epidemic. And so any opportunity that we have to find alternatives to opioid use is very key. And specifically in the context also of, recovery in orthopedic surgery, opioids have a lot of side effects that delay recovery. So weakness, sedation, reduced respiratory drive, things like that. And so again, we're trying to eliminate them as much as we can, or introduce agents that will reduce our patients' pain enough that they are opting to take opioids for pain less. So either one, but our role in the context of this epidemic is very significant, something that I wasn't aware of before, and I think is very important to take into account.
Thank you. So we're going to stop there. Thank you, Alexandra, for a great presentation. We're going to move on to Jacob Schneider. Jacob's project has been supported by the Joe Namath Foundation. Jacob, take it away.
Okay, can everyone hear me? All right, so this summer, our study looked at the socio-demographic factors associated with pediatric cochlear implant compliance. So cochlear implants can have a tremendous impact on one's quality of life, especially a child as they're learning to talk, process speech, and are still undergoing cognitive development. And once one receives a cochlear implant, it's very important that they attend several follow-up appointments, especially within the first year. These are referred to as mapping appointments. And it's also recommended that you wear your cochlear implant during every waking hour in order to achieve optimal results. This is referred to as data logging, and it can be directly tracked by one wearing a cochlear implant. So different factors associated with compliance have yet to be explored among the Long Island population. So that's what we looked at this summer. And this image below shows a cochlear implant, which consists of a microphone that captures the sound and then an external processor that converts the sound into a signal and transmits it to the internal processor, which further converts it to an electrical signal that directly is implanted into the cochlea and stimulates the auditory nerve going to the brain. So this summer, we hypothesized that socio-demographic factors, including ethnicity, race, insurance type, primary household language, and immigration status, may influence one's cochlear implant compliance, which we measured by the number of appointments that they attended within the first year after receiving a cochlear implant, in addition to how long they were wearing their implant at the 6-month time point. So our methods for the study, we performed a retrospective chart review of 107 patients that received a cochlear implant over the last about 10 years. And we recorded several different variables in REDCap, in addition to things such as the age of their first amplification, the age they were diagnosed with hearing loss, and the age that they received a cochlear implant. And then we performed some different statistical analyses. So this chart over here shows the general characteristics of our patient population. So as you can see, there's a very diverse patient population that receives cochlear implants. About a third of our patients do not speak English as their primary language in their household. And majority of our patients have Medicaid or another managed care as their main mode of insurance. This middle chart here is comparing the data logging hours, which we broke up into more than 8 hours a day and less than 8 hours a day among several different variables. So we looked at insurance type, ethnicity, primary language spoken, and immigration status. So our study actually showed that there was no difference among these groups, and most patients actually wore their implant at this 6-month follow-up, regardless of these variables, less than 8 hours a day. And then lastly, we ran a t-test looking at the number of appointments within the first year post-implant. And we didn't find a significant difference among insurance type and also those who were born in the US or immigrated to the US. However, I would like to state that all of these different sociodemographic variables were still considered compliant, as they still attended more than 5 follow-up appointments within the first year. There was a greater difference among those born in the US and those who immigrated to the US, as there were a difference in about 2 appointments per year. So wanted to reiterate that most patients did wear their cochlear implant for an average of less than 8 hours and did attend several follow-up appointments and were considered compliant. So to continue with the study, we want to look at other factors that may influence patient compliance, such as the socioeconomic status, as we did record patient zip code. And then we also want to stratify the populations by age to see if that influenced data logging hours. And lastly, we want to look at the different barriers to scheduling cochlear implants and also wearing the cochlear implant among different populations, and increase education among those following up with Northwell and who received a cochlear implant.
Thank you. So we'll go ahead and open it up for 5 minutes of questions.
I have a question, Jake. What do you know what the kind of education is that families get before making a decision about getting a cochlear implant?
Yeah, so they will initially kind of go through this entire screening process to see if they're eligible, and then once they are deemed eligible, they attend several appointments with audiologists, and that includes different like educational sessions on what kind of a cochlear implant is, the follow-up required, and like many different resources such as like referrals to early intervention that sort of help support them and educate them before making like the big decision of getting a cochlear implant.
I also have a question. Just real quick, when you mentioned stratifying by age in the future, can you just talk a little bit more about like why age specifically, or what you expect to see there?
Sure. So for different variables such as how insurance didn't show differences in data logging hours, we want to look at if maybe those with private insurance tended to get their cochlear implants at a younger age, and maybe that was what was influencing the lower data logging hours compared to those with Medicaid or managed care who may be older and also wearing their implant for less hours. Thank you.
I have a question. So your age range is very large, from newborns to 18-year-olds. I know you haven't stratified by age, but in looking through your data, did you have any sense whether, because compliance in an infant or a small child is a function of the parents, and compliance in a teenager is the teenager. Do you think that there's going to be a big difference in time of use for the two groups?
So that's a good question. I think that there may be a difference, but in many of the patients that get their implant at younger ages, they have certain devices that kind of keep the implant on in case a child is ripping them off. So I think like certain factors like that also may influence it other than parents. But overall, I think there would be a difference, especially because younger children are maybe referred to different programs like early intervention. And I wouldn't say that it's necessarily all the parents, like the factors that are influencing it. So I think maybe that should be explored more.
I have a question about the existing literature prior to you undertaking this project. What did the existing literature talk about in terms of pediatric cochlear implantation, compliance, and socio-demographic factors? Or was there any literature out there that was really extensively talking about that?
So there was literature, but I didn't see much exploring actual data logging hours associated with the different factors. So it's established that data logging hours do influence the outcomes and results, but it was yet to be really explored, especially among like New York City and the diverse population in Queens and Long Island, and how the data logging hours may be different among those populations. So that's kind of what sparked the study.
I think we have time for one more question, if there is one more question. I guess I have one follow-up question, not so much about the literature, about the demographic variables that you talked about. So you were saying that demographic variables were collected during the follow-up appointments or several time points throughout the study: activation, first follow-up, 6 months, 1 year, and 2 years follow-up. Was all demographic information collected like completely, or were there pockets of information missing from the charts?
Yeah, so that was one of the limitations. So several patients were lost to follow-up after receiving the implant, whether that was they just stopped attending appointments, they moved out of the area. So we did collect as much as we could from all of the patients, but that's why for our initial analysis, we looked at 6-month follow-up specifically and the 1 year post-implant, because that was like a really good gauge for kind of their use, and it also had the most data for now.
Great. Thank you, Jacob. So we'll go ahead and move on. Thank you so much for a great presentation. Our next presenter is Julia Tatro. Her project has been supported by the Korn family. Go ahead, Julia.
Can you hear me okay? My project, under the guidance of Dr. Jesus Kumar and Dr. Mark Gordon, thank you for attending, Dr. Gordon, was titled Association Between Tau Imaging, Plasma p-Tau, and Atrophy in Alzheimer's Disease with and Without Psychosis. Alzheimer's disease is characterized by pathologic accumulation of amyloid plaques consisting of beta amyloid protein and intracellular neurofibrillary tangles consisting of hyperphosphorylated tau protein. And psychosis in Alzheimer's disease represents a distinct phenotype, and in previous work, cross-sectional PET imaging has shown that tau protein pathology is associated with psychosis and more rapid cognitive and functional decline in Alzheimer's disease. And the two groups in our study included the AD plus P group, which refers to patients with Alzheimer's disease and psychosis, and the control AD minus P group, which was comprised of individuals with Alzheimer's disease and no diagnosis of psychosis at any point before or during the years of data collection. And the aim of our study was to address longitudinal differences between the two groups in 5 main areas. 1, cortical tau PET, 2, cortical thickness, 3, subcortical tau PET, 4, subcortical volume, and 5, plasma p-tau slope predicting future tau PET uptake in the brain. Plasma p-tau refers to the phosphorylated version of tau protein that can be found pathologically in the bloodstream. And we utilize the Alzheimer's Disease Neuroimaging Initiative database for MRI data as well as PET imaging data using the radiotracer fluortosipir, excuse me, which binds with high affinity to hyperphosphorylated tau. We had a total of 68 subjects with 47 in the AD minus P control group and 21 in the AD plus P group. For the cortical and subcortical data, structural MRI images were manually pre-screened and processed using FreeSurfer software. For subjects with more than one time point, a template or base image was created using information from all time points for that subject. And this base was screened for accuracy in white matter and peel surfaces and edited when necessary. A longitudinal run was completed for subjects with multiple time points, and this longitudinal run was co-registered with the PET image closest in date to that MRI. The co-registration was inspected and adjusted using FreeSurfer segmentation as a guide. For the plasma p-tau analysis, this data was acquired over a 3 to 5 year period, approximately 1 year prior to the tau PET data acquisition. We calculated slope of change in plasma p-tau to predict future tau PET uptake. Only 42 subjects were available for this data, with 29 in AD minus P and 13 in AD plus P. Some of our results were non-significant. Specifically, there was no significant difference found between groups over time in longitudinal cortical tau PET, subcortical tau PET, and subcortical volume data. Interestingly, there was a non-significant trend suggesting that AD minus P had a greater increase in tau burden over time than AD plus P, and this was in contrast to our initial hypothesis. One possible explanation may be that the AD plus P group at baseline started with more tau burden than the AD minus P group, and so over time they did not increase their tau burden due to a ceiling effect. And we would like to explore this non-significant trend further in the future. As shown in figure 1, plasma p-tau slope in subjects from both groups predicts future tau PET in the cortical areas indicated in red, including right fusiform, right inferior temporal, right medial orbitofrontal, right lateral occipital, right lateral orbitofrontal, left caudal middle frontal, left superior frontal, and left post-central. This suggests that plasma p-tau is associated with brain tau burden and that tau pathology in the blood may be detected earlier than tau PET aggregation in the brain. However, we were not able to assess concurrent blood and brain PET measurements to evaluate this relationship to its full extent. And as shown here in figure 2, analysis of longitudinal cortical thickness in the right hemisphere only showed significant atrophy in the rostral middle frontal and pars triangularis cortices in the AD plus P group, shown here in blue. This suggests that atrophy in these frontal lobe cortical areas may be associated with psychosis in patients with Alzheimer's disease. And longitudinal cortical thickness results also showed significant atrophy in the fusiform and parahippocampal cortices in the AD minus P group, shown in red here. This supports previously established data showing increased tau burden in these temporal lobe areas in Alzheimer's disease in general, not necessarily associated with psychosis in Alzheimer's. And the left hemisphere showed no significant differences in this longitudinal cortical thickness data. So thank you for your attention, and I can now take any questions you may have.
Thank you, Julia. So we'll open it up for 5 minutes of questions, please.
I have a question. Were there differences in the duration of time that they had been diagnosed between the patients with and without psychosis?
Their diagnosis with Alzheimer's disease.
Yes.
I am actually not sure if I don't know that data, actually. That's a very good
Because
question.
you speculated that they might have that those with psychosis might have a higher tau burden to start
Oh,
with.
There was we do have the baseline age of when we first started getting this MRI data. So I don't know when they were diagnosed, but when they first started getting these MRIs done, their baseline age had no significant difference between the two groups. If that's helpful, but yes, I'm not sure I know that answer. It's a good question.
Liam, go ahead.
Hi, thank you so much, Julia, for sharing. Just one question I was thinking, maybe can you explain a little bit about how this work could inform indications or development of treatments for these conditions? Like, how could this inform therapeutics for the diseases that you study?
That's a really good question, Liam. I have thought of this more in implications for diagnostics, specifically the plasma p-tau data would be really interesting if we were able to pick that up earlier for patients. Then perhaps if we had therapeutics we could start earlier, that would be certainly very interesting. And perhaps with this information that the p-tau specifically being associated more with psychosis, if we see patients that are presenting more with psychotic symptoms, then perhaps we need to be able to start a treatment that specifically works for tau. I don't know a lot of therapeutics that are able to do that. I think a lot more right now are for the beta amyloid plaques. But perhaps if that were worked on in the future, then specifically for people with psychosis, that could be really helpful for them.
This is more of a kind of a logistical question, but in your methods, you mentioned that you examined the Alzheimer's Disease Neuroimaging Initiative database. Can you tell me more about that database?
Sure. It's a national database that has a lot of data, like MRI data, PET data, serum data, genotyping from patients with Alzheimer's disease all across the country. So it is very incorporative of a lot of different populations, and it's a public database as well. So it's very easy to access, and it has almost anything you could ever want to analyze. So it's a really great resource.
Thank you. And I actually have a follow-up question to that. I apologize if you had already mentioned it in your talk, but you also mentioned that the images were manually pre-screened. What were the pre-screening criteria? Unless I've interpreted that incorrectly. I apologize if I did.
Yeah, so that was kind of my role this summer. So the Free Surfer software is very interesting, and you can put in MRI data and it will tell you where it believes the gray matter line is and where the white matter line is. So it can distinguish itself where gray matter, white matter are and all the different areas of the brain. And so my role and another undergraduate student's role was to go in and make sure that that was accurate. So if it was saying that the gray matter line should be in a certain spot, and then I went in and I realized that that was not where it should be, then that was this pre-screening tool. And so I could go in and fix that and tell it, no, this is where it should be. And then we would run again, and I would check and make sure that it fixed the issue.
Thank you. If just want to pause to see if there's any additional questions. Okay. All right. Great, Julia. Thank you so much for a great presentation. So we'll move on to our next presenter, Nora Donahue. Her project has been supported by the Joe Namath Foundation. Go ahead, Nora.
Sorry, one second. Can you all see my screen?
Yes.
Okay, so my study this summer was on necrotizing enterocolitis, which is a bacterial infection of the intestinal wall that affects primarily preterm infants in the NICU and is one of the leading causes of morbidity and mortality within the NICU. And so far, we know that necrotizing enterocolitis is associated with a low birth weight, preterm birth, especially under 36 weeks. It is also associated with the use of formula feeding as opposed to breast milk. And it is related to a similar condition called spontaneous intestinal perforation, or SIP, which also has a very high mortality rate among infants, specifically in the NICU. NEC can be managed medically with antibiotics, usually for about 7 to 10 days. But in severe cases, when the infection gets so bad that the intestine perforates, emergency surgery is required and a bowel resection is performed, both in the case of surgical NEC and spontaneous intestinal perforation. And these operations can have a very high complication rate. And if the disease gets to this point, the mortality rate is typically above 50%. And there's currently not substantial research on other factors that influence outcomes of patients with surgical NEC and SIP. And since they both have the highest mortality rate within the NEC family of conditions, we decided this summer to focus our attention on potential risk factors and associations that would help us identify these conditions as early as possible, and so that physicians can prevent them from progressing to the need for surgery. So we hypothesize that there does exist a correlation between the age of onset and birth sex and the outcomes of surgical NEC and SIP patients. So over the summer, I contributed to an ongoing prospective chart review that began in July of 2021. So it's been going on for over 2 years at this point. And we were screening all NICU patients who were on antibiotics in the NICUs at Cohen Children's and at North Shore. We enrolled a total of 99 patients. That number has actually gone up to about 105 in recent weeks. And 30 of those patients were diagnosed with spontaneous intestinal perforation or surgical NEC. And the outcomes that we used were the rate of bowel resection, the mortality rate, the time to full feeds, which was defined as 100 milligrams per kilogram of weight, and the length of stay in the NICU. And we compared that across 3 groups. So the first cohort was based on birth sex, male or female. The next cohort was based on the age of NEC onset, earlier onset defined as less than 10 days of life, and later onset defined as after 20 days of life. And then for the age of SIP onset, early onset was defined as less than 7 days of life, and later onset was greater than 7 days of life. And these parameters were based on pre-existing literature. And as you can see in our results, there were not significant differences observed within each cohort with regards to the outcomes based on birth sex or the age of onset, which contradicted some of the findings in several previous studies, which I thought was interesting, where they did find some significant differences. The only finding that was close to being statistically significant was the age of NEC onset and the time to full feeds. So patients with an earlier NEC onset had a longer amount of time until they reached full feeds, which can have some implications for their growth and development later on. And then in conclusion, more data is needed. We only had 30 patients, so the sample size was not too large. And we are looking forward to analyzing some other potential risk factors associated with surgical neck outcomes and SIP outcomes, such as comorbidities, maternal comorbidities, like intrauterine growth restriction and gestational diabetes, as well as some congenital heart defects for the babies. With the goal of diagnosing this earlier and helping physicians predict who is most at risk so that we can reduce mortality and complications in the long run.
Thank you, Nora. So we'll open it up for some questions.
So I have a question. From other things that I have read, in general, male babies don't do as well. They have higher risks for a lot of other things as well. Is the difference between the two genders greater for neck and for this than for other disorders, or do you know that?
So I did see some studies in my research that saw what they called significant differences between a male and female patient outcomes in neck. And but in our study, we did not see that. And I'm not exactly sure of the reasons why, because in the studies that I read, they had similar had a similar weeks of gestation at birth. They were both preterm infants, and the male and female patients that tended to do the worst had the earliest birth date in terms of months of gestation. But to my knowledge, there is no consensus as to why male patients might do worse than female patients.
It might just be a numbers thing. You might need bigger numbers, and then it might become more significant.
I agree. And in our study, as you can see here in this top figure A, we only had 19 male patients and 11 female patients. So of course, there was the difference in the number of both male and female patients. And then both numbers are so small that we really just need a lot more data.
I have a question about figure B and C. Can you explain the DOLs for both figure B and C? I noticed the one is the numbers are different, but was there a reason for that?
Yes, it was based on pre-existing literature. That is just the sort of standardized definition of early onset neck and then early onset spontaneous intestinal perforation based on a large collaboration of data on both conditions. Spontaneous intestinal perforation tends to occur a little bit earlier on, and there's a narrower time frame in general, which is why we have the 7 days of life versus 10 and 20 for neck. And within the neck category, there are further divisions. There's like an intermediate day of life onset. But for the sake of simplicity in this analysis, my P&I thought it would be best to just go with less than 10 days of life and greater than 20. But it was largely based on just pre-existing literature and the general consensus.
And can I ask you one more question?
Of course.
What would you like to do next if you were continuing this study? Where would you go with it if you
So
if you
I'm
had
interested.
a year to do this full time?
Of course. Well, some of the other risk factors that I mentioned, I think might be worth studying. And the reason that they weren't included here was just because with our small sample of patients, there wasn't enough similarities across groups to sort of analyze the data, if that makes sense. So things we noticed were intrauterine growth restriction, which of course is related to many poor outcomes for the baby. We noticed that in some mothers, that was something that may have predisposed the infants for NEC and SIP. And I would also be interested in studying the correlation between congenital heart defects and NEC, since we noticed that a lot of babies had PDAs or patent ductus arteriosus that required treatment. And we didn't look into that too much. We didn't have a ton of patients with that risk factor, but I would be interested as our sample size grows to explore that in the future.
Great. Thank you, Nora. Thank you for a great presentation. And we'll move on to our next presenter, Dr. Steinberg, if you want to introduce them, please. Oh, you're muted. Dr. Steinberg, you're muted. One moment, let me send her a message.
Hello? Are you able to hear me?
Yes, go ahead.
Okay. So you didn't hear what I just said? Oh, because it should have unmuted. It said it was. Okay. So our next presentation is by Oluwatu Omalabu, and she's also supported by the Joe Namath Foundation. Take it away.
All right. Share screen here. All right. Good evening, everyone. This summer, we worked on evaluating the microbiologic evaluation of the debris on the base of the eyelash and the eyelid margin in patients who have been diagnosed with blepharitis. So to start off, blepharitis, plainly put, is the inflammation of the eyelids. It can present as very red, swollen eyelids that can have a burning or sore sensation. You would also see what we like to call cylindrical dandruff along the eyelid margin. And it's very common, especially among people who have other skin issues such as rosacea and dandruff. Blepharitis can either be anterior or posterior. Anterior meaning that the cylindrical dandruff and the debris are located more along the eyelash, while posterior is more in the inner corner of the eyelid towards the eye. So in terms of what can cause blepharitis, it can be an array of things, including improper lid hygiene, meibomian gland dysfunction, and meibomian glands are glands that are located on the inner eye, which produce oil that helps with our tear production, and also overpopulation of little mites that exist on our skin called Demodex. So the eyelid has a biofilm that starts to, I guess, accumulate bacteria from the moment that we are born, and bacteria begin to colonize in these areas. The eyelid has a lot of moisture and nutrients and warmth, which is a perfect breeding ground for bacteria, as we're learning. So our purpose of our study was to use electron microscopy to visualize the biofilm of the lid margin and also visualize the constituents of the biofilm before and after a procedure called microblepharoexfoliation, in which a small tool is used to kind of remove the scruff on the eyelid, and patients, in this case, 10 patients were selected to be part of this study, in which we use fungi tape to do a pre and post of the biofilm, and was sent to the lab to be evaluated under electron microscopy. So as one can see here for the results, oh, sorry, it's not letting me zoom. Okay, there we go. Yes, so for figure 1, we have panel A and B, which were taken from control patients. So these are patients who do not have blepharitis prior and after the microblepharoexfoliation treatment. And as you can see, this is what we consider typically normal. Under it, you can see that first off, A and C panels are low power shots with the red squares zoomed in B and D. And this is the pre microexfoliation of patients who have blepharitis. So after the procedure is done, you can see on the right side, the right panel, that there is less of the colonies of the bacteria and less overall bacteria infiltrating in these areas. So our conclusion was that the analysis of the biofilm was significantly reduced in bacteria as we expected after the microblepharoexfoliation, and also we were able to test for the presence of specific bacteria and able to see that a lot of the bacteria that we expected to see on there that basically colonize on our skin daily, like coagulase negative staphylococcus bacteria, were also present on the eyelid film. Thank you.
Thank you, Oluwatosin. We will now move on to 5 minutes of questions.
So I have a question. Is this exfoliation procedure uncomfortable? And how, if you wanted to use this as a treatment, how often would you have to do it? Because bacteria proliferate very rapidly.
Right. So yes, no, this is a really good question. No, the microblepharoexfoliation is not harmful, and patients actually have said that it feels almost like you're getting a massage on the eye. The tool that is used is very small, and it basically feels like a little micro sponge, just kind of like the way you would exfoliate your skin. But it's done for the eyelid, and it's done by an ophthalmologist. So it's usually like not painful for the patients. And in terms of how often it's done, we were told within like 3 months, three to 4 months, the patients come back and have it done again.
Are there other questions?
I do have a follow-up question to that. Is this typically the gold standard for treating blepharitis, or is there a different gold standard when it comes to this type of treatment?
Yeah. So as I stated, blepharitis is a very common condition that happens to like almost everyone. And initially we ophthalmologists normally recommend homeopathic remedies such as like warm like cloth on the eyelids, just to kind of get the debris and the gunk off. But for patients with real chronic blepharitis that, you know, has complications down the road of like possible injury to the cornea or recurrent like styes or chalazions, they would recommend this type of procedure for them.
Are there other questions? So I have one further follow-up question. Was there any difference that you noted in your population between those who have MGD and those who don't?
So that's a really good question. That's something that I think we would be exploring further in our next steps, to have more, first of all, to expand the study to more patients so that you can take more of a detailed history on patients who do have meibomian gland dysfunction, and therefore be able to compare and contrast the the results of the microblepharoexfoliation in these patient populations, but that is something that we didn't really cover with our study as yet.
And I'll ask the final question because we have just a minute more, and that's my favorite question. What would you like to do next with this project?
Yeah. So as far as next steps, I would love if we could do more quantitative measures. So we use chocolate and blood agar plates to just kind of test for like what bacteria that we were expecting to see in the biofilm. But I feel like it would be really cool if we could have a quantitative measure of how many colonies grew as we collected the information, and we could take a look at the results and see, as you mentioned, like if they were varied among different populations within the patients who have this blepharitis. And yeah.
Okay, if there are no other questions, thank you very much. So our next presenter is Liam McGurk, and his project was supported by the Vincent Vinciguerra Dr. Jonathan Kolek's Endowed Summer Research Stipend, supported by Dale E. Zand, PhD. Liam?
Sure, I'll share my screen. All right, can everyone see it? Actually, I can't see all of you, so I don't know if you're saying yes or no. Can someone unmute?
Yes, we can see your screen.
Okay. Okay, perfect. Hi, everyone. Good evening. I'm Liam. So my project is called Organ Dosimetry in Lung Cancer Screening. Differs based on sex, race, and body habitus. Just for some context, lung cancer is the leading cause of cancer-associated death, and advancements in lung cancer screening have significantly reduced mortality from lung cancer. In 2021, the U.S. Preventive Services Task Force expanded lung cancer screening to adults aged 50 to 80 years who have a 20-pack year history of smoking and currently smoke or have quit within the past 15 years. This would amount to as many as 30 low-dose CTs, and that level of radiation exposure is concerning, especially when we consider the synergistic carcinogenic effect of tobacco and radiation. Besides radiation, lung cancer screening can lead to false positives and unnecessary invasive workups as a follow-up of lesions identified in screening. My study estimates organ-specific radiation dose in the context of lung cancer screening and identifies differences in radiation doses based on patient characteristics, including sex, race, and BMI. These data inform future efforts to estimate downstream risk of malignancy due to participation in lung cancer screening. This is a retrospective cohort study, and I included patients who had low-dose CT for lung cancer screening in 2020 through 2022. Patient race was self-reported at the time of the scan. Scans were excluded if patient sex was misinterpreted by the radiation dose monitoring system. Organ doses were calculated from patient and scan-specific Monte Carlo simulation using best fit Christie phantoms by Radiometrics. So I know that's a lot to digest. In simpler terms, the organ doses were determined for each patient using scan-specific models to improve the accuracy of the organ dose calculations. For the results, I'll focus on the key points, and there are supplemental figures and tables attached through the QR code. So from greatest to least, the organs receiving the most radiation exposure from low-dose CTs across all of the patients in the study were thymus, lungs, breast, and heart. In terms of race, African-American patients had 5 millicentimeters of additional total radiation dose on average compared with white patients, and an additional 15 millicentimeter average total radiation dose greater compared to Asian and Pacific Islander patients. In terms of body habitus, obese patients received a greater total radiation dose from low-dose CT, which is 141 plus or minus 87 millicentimeters, compared with non-obese patients, which was 71 plus or minus 23 millicentimeters. Moving on to our conclusions, the ideal frequency of performing low-dose CT for lung cancer screening is critical, but remains incompletely understood. Since obesity is a known risk factor for multiple cancers, the dose of long-term diagnostic radiation and subsequent cancer risk must be better understood to inform screening cadence, especially for obese patients. To our knowledge, the race-specific differences we describe are the first to be reported in patients undergoing lung cancer screening. Recognizing racial differences in lung cancer susceptibility, the higher receipt of radiation exposure from lung cancer screening in African American patients is noteworthy, since lung cancer incidence is actually greatest in African American men. Our study is limited in that we report uncorrected radiation doses. The differences we identified in radiation received by race and sex are likely related to patients' body habitus and BMI, but since only some patients have BMI data, we were not able to completely control for this confounding factor. In conclusion, to determine individual and organ-specific risks related to radiation from lung cancer screening, accurate estimates from diverse and real-world populations are necessary. And this study identifies organ-specific radiation dosing, as well as 3 patient-level factors influencing dose: BMI, sex, and race. Using this baseline knowledge, future work may provide estimates for an individual's risk of developing cancer as a function of lung cancer.
Thank you. Are there questions? So I have two, so go ahead, Mark. I'll let you go first.
All right, so I'm just trying to understand what the basis is for that racial difference. Is it different number of scans, or I'm not sure what's driving the difference in radiation exposure.
Yeah, and neither are we. It's really not clear why. We think that the BMI is a leading confounding factor to continue investigating and seeing if there were BMI differences between the different race groups that could perhaps explain some of the variation, but we don't actually understand because this is on a per scan basis. So we're saying per each individual scan, an African-American patient receives more radiation, but we're not exactly why that person has a higher dose exposure than someone who's not African-American. Like, that part is not clear.
So I had a related question to that. When you do a low dose scan, a screening scan, do they adjust the dosage for the patient's BMI?
Yeah, so during the low-dose CT scan, there are like guide images taken, and those guide images help the radiology technician to determine the appropriate radiation dose to generate an image that is of diagnostic quality. So patients that are just physically larger need to have a greater radiation dose exposure so that the plate underneath the patient can be exposed with enough radiation to generate a diagnostic image. So those patients just naturally receive more radiation dose to generate the images of the necessary quality for diagnostic use.
Okay, that's what I didn't understand. Are these doses differences that you see as 5 milligray? Is that per scan? Based on what we know about risk factors for radiation, and I know there's no zero risk. There's no dose that's low enough that there's no risk. But do you think these are significant if you had, every year or every couple of years?
So based on the preliminary work and the existing literature, it's like the preliminary part of the follow-up to this, which is estimating malignancy associated with the radiation exposure. And based on what other people have done in the past, it does present a noticeable risk, especially when the recommendation amounts to as many as 30 scans. That presents a real risk for development of cancer. So I guess continuing to investigate how much is the right amount to really hone into cadence to optimize both early detection and risk reduction. I guess that's like the key part, but it is a measurable and noticeable.
I have a question, Liam, that you may or may not know the answer to, but I know we learned for spirometry that at least at some point they were entering data for race into the machine. Do they do that for these scans as well?
So for these scans, race is self-reported. So the patient reports their race to the radiation technologist, but I don't know if it's inputted like into the machine to compute like a dose throughput. I don't think that happens, but I'm not entirely sure.
That's okay. Thank you.
I have a follow-up question actually to the race component. So since race was self-reported for the patients, would you say that a majority of them did actually self-report their race, or was there some of your conclusions or results were like race-based? So I'm just wondering like what percentage actually disclosed their race and what percentage did not.
Yeah, sure. I can get that 1 second. I don't remember off the top of my head. And there was only so much space on the posters.
Yes, of course.
Yeah, so basically every patient had a recorded race. So all 13,431 people had a recorded race. Of those people, 2,020 was like other. And then there were 1,047 African American self-identifying individuals. That's 7.8% of the study population. 348 Asian Pacific Islander self-reporting individuals, 2.6% of the study population. 10,016 white individuals, 74.6% of the study population. And 2,020 people who self-reported as other. And that includes Hispanic, Native American, multiracial, declined, other, or unknown. And that's 15% of the study population.
Great, thank you so much. With that, thank you, Liam, for a great presentation. And we will move on to the next presenter.
So our next presenter is Nicholas Leung, and he's supported by the Joe Namath Foundation. Nick?
All right, let me just share my screen. So I hope everyone's having a pleasant night. I have a little bit of a cough, so I might have to mute myself if I have a coughing fit. So I apologize in advance for that. So my name's Nick, and I'm excited to share some of the research I had the chance to do over the summer with Dr. Andrew Tiercy at the Manhattan Eye, Ear, and Throat Hospital in Manhattan. Dr. Tiercy and I worked on a project focusing on glaucoma, which is a common ocular pathology that can lead to blindness. The traditional theory of glaucoma is that it is caused by increased intraocular pressure, but recent studies have found that other factors, including microvascular changes, may also play a role. One way to measure this is by using optical coherence tomography angiography, or OCTA, which is a technique that scans the retina using a laser. Multiple images can be compared, and because red blood cells are the only moving object in scans, we can isolate those moving particles to give us an image of the retinal blood vessels. Dr. Tiercy's lab has shown correlations between OCTA measurements and ganglion cell function tests. Other studies have also shown differences in vascular physiology between the superior and inferior retinal hemispheres. So in this study, we sought to further explore the vascular basis of glaucoma in regards to the superior-inferior disparity by investigating the correlation between OCTA scans and Humphrey field analysis, a type of visual field testing. We hypothesized that the retinal hemisphere with a loss in visual acuity would be correlated with a decreased vascular density as measured by OCTA. 47 eyes of glaucoma suspects were enrolled in a cross-sectional study in which the participants underwent visual field testing and OCTA imaging. The OCTA images were analyzed using image J-code that I wrote. We calculated vascular density for the following regions. So we calculated for the superior and inferior macula, which is a rectangular region of interest. We calculated it for the superior and inferior parafovea with the FAS removed, the foveolar avascular zone in the middle here. And we calculated it for the superior and inferior parafovea with the FAS included. So partial correlation analysis of 29 eyes showed significant associations between HFA PSD 10-2 and the vascular density of the inferior parafovea, regardless of whether the foveolar avascular zone was included or not. This indicates that decreases in vessel density in the inferior retina were associated with decreased visual acuity in our dataset. These findings are consistent with other studies, which have correlated visual field changes with decreasing vessel density. Initial scotoma in glaucoma often occur in the superior visual hemisphere, which corresponds to the inferior retinal hemisphere, which is also consistent with our results. These results may be due to the superior retinal hemisphere getting more blood flow than the inferior, predisposing the inferior to glaucomatous change. The field of ophthalmology is trying to move away from visual field tests as they are subjective and demanding of our patients. Using objective testing, such as OCTA, will take this burden off of the patients while also catching glaucoma before any irreversible visual field defects occur. Future studies should look into other OCTA techniques, such as posterior pole asymmetry analysis, to further study the difference in vasculature between the superior and inferior hemispheres in glaucoma. Thank you for your attention.
Thank you. Are there questions? I'd like to start with one. You only did an analysis on a subset of the 47 eyes that you originally enrolled. Why is that?
So some of the patients were missing data, so they weren't able to be included in the analysis. Some of them didn't have OCTA scans, and some of them were missing information such as age and sex and race, things like that.
Dr. Gordon?
Yes, thanks. So I guess you were looking at a patient population that was suspected to have glaucoma. And I'm wondering if you just look at normals, are there hemispheric differences in vascularity intrinsically? And furthermore, I guess that would speak to whether this could be used as a early screening pre-symptomatically in patients who don't have detectable visual impairment.
That's a good point. And there have been studies that have shown that there are differences in the vascular densities of the superior and inferior retina, even in healthy patients. But I would expect these differences to be more pronounced in glaucoma patients and glaucoma suspects.
So I'm going to ask you my favorite question. If you had a year to work on this full time, what would you want to do?
So Dr. Tercy and I are still working together, and I really enjoyed coding with ImageJ over the summer. So I'm using my knowledge of ImageJ to automatically remove the foveolar avascular zone from these images. You can see that it's manually drawn here as a circle in this study, but we're looking to use image processing code to automatically remove it from these images in future studies.
Are there other questions?
I have one question. So in the future direction portion of your poster, you indicate that HFA is a very subjective functional test, in addition to it being time consuming and poor reproducibility. Was there a reason why that was used in particular for this, knowing those limitations?
Yeah, definitely. That's a good question. So currently for glaucoma, visual field tests are the gold standard. And because of historical reasons, these visual field tests are just what have been used for glaucoma patients. But as newer technology emerges, we're trying to move away from it, because it really does take a long time. It takes about 3 minutes of the patient's undivided attention to measure visual field tests. So if we could use a scan like OCTA or PPAA, it would be much quicker. It only takes a few seconds. So, and it would be more objective.
Thank you.
Are there any other questions? All right, if not, thank you very much. And we will move on to the last presentation, which is by John Habert. And his work was supported by the Linda and Leonard Sussman family. So take it away, John.
Okay. Good evening, everyone. Just give me 1 second to set up, please. Can everyone see my screen?
You
Yes.
want to switch to, okay, now you did. Fine. It's
Okay.
fine.
Thank you. So hello, everyone. My name's John Habert. I'd like to thank you all for attending our research day today, and I'd especially like to thank Mrs. Linda Sussman for providing the generous financial support for me to pursue my research project. I'm still currently in the process of conducting my research project titled Using Echocardiographic Parameters to Predict Hypertensive Disorders of Pregnancy at Nassau University Medical Center, also known as NUMIC. So I'll start off by giving a little bit of background into hypertensive disorders of pregnancy. They're extremely common today, and they can have severe consequences, including fetal growth restrictions, placental abruption, preterm birth, as well as heart attack and stroke. They are currently the leading cause of maternal mortality in industrialized nations, including the United States. So what exactly are hypertensive disorders of pregnancy? It's a group of conditions. And if you look at the little flow chart I have over here, they're all diagnosed by persistent systolic blood pressures of at least 144 or 140 millimeters of mercury, or diastolic blood pressure of at least 90. If it occurs before 20 weeks gestation, it's considered chronic hypertension. And if it occurs before pregnancy or at least 12 weeks postpartum, then that number is actually a little bit lower. The systolic blood pressure is 130 and the diastolic blood pressure is 80. If it occurs after 20 weeks of gestation and there's no features of proteinuria or severe features, it's considered gestational hypertension. And if there is proteinuria or severe features, which include signs and symptoms of end organ dysfunction, it's considered preeclampsia. Eclampsia is just preeclampsia, but with seizures. And then HELP syndrome is an acronym that stands for hemolysis, elevated liver enzymes, and low platelets. Besides the kind of short-term acute consequences of hypertensive disorders of pregnancy, they've also been shown to have long-term health implications. These include a fourfold increased risk for heart failure and a twofold increased risk for atherosclerotic cardiovascular disease. Many of these long-term health implications can be attributed to the development of chronic hypertension after hypertensive disorders of pregnancy. There was a study that was kind of the motivation for our study, that they took transthoracic echocardiograms 3 months postpartum, and they discovered several findings that were correlated with the development of chronic hypertension after hypertensive disorders of pregnancy. While the findings of this study may be able to address those long-term complications we talked about, it doesn't do anything to address the many complications that occur during pregnancy. Currently, screening for hypertensive disorders of pregnancy occur during prenatal visits by measuring blood pressure. This is useful in the diagnosis of hypertensive disorders of pregnancy, but does little for the early detection and prevention of hypertensive disorders of pregnancy. So the purpose of our project is to investigate if there are transthoracic echocardiographic findings that are linked to the development of hypertensive disorders of pregnancy, with the hope of developing a screening tool that will allow us to identify at-risk patients for early intervention. Our hypothesis is that there are echocardiographic parameters that can be used to predict the development of hypertensive disorders of pregnancy in women with no prior history of chronic hypertension. And this project is being conducted via a retrospective chart review. We received the billing codes of 21,000 unique patients at NUMIC, and then we kind of separated that into outpatient and inpatient, and then isolated which patients had hypertensive disorders of pregnancy. We decided on a patient population of 427 patients who were seen between October 2015 and July of this year, who were seen in an outpatient status with hypertensive disorders of pregnancy. We decided to go with those patients in an outpatient status because we figured there'd be less confounding variables. Some of the parameters we're currently collecting include looking at left ventricular systolic function, left ventricular geometric changes, right ventricular systolic function, the presence of diastolic dysfunction, left atrial volume, EA ratio, and pulmonary artery systolic pressure. We're currently in the process of data collection, but once we're complete that, we'll go ahead and conduct our statistical analysis. And then once we're done with that, some possible future directions is looking if the trends will remain the same among inpatient populations, and then looking into how this data can be incorporated into a screening tool to better inform clinicians.
Other questions? I'm sorry, did I interrupt you?
No, you're fine, Dr. Stomberg. I was just going to ask if anyone had questions.
All right, are there questions? So do you have any data yet? Or are you still in data collection mode?
We currently have data from about 30 patients, but we're still in data collection mode. It took a little while to get the IRB approved and then to get access to the charts.
Do you have a sense of what statistical analysis you're going to be using or applying?
That's a good question. I don't yet. I have to sit down with some of the statisticians at the hospital and discuss that.
And when it comes to timeline of your project, you just described kind of where you are currently, but what does it look like from this point forward? How long do you think till the next step and the conclusion of your study?
There's currently 3 of us working on the data collection, so I think we should be able to get it done within probably about 2 months.
So I have a question about your decision to go with the outpatient population. Can you describe a little more why you made that decision? Isn't the inpatient possibly more likely to have positive findings?
The reason we went with the outpatient population is because we were trying to develop a screening tool to predict those the hypertensive disorders of pregnancy, that especially the ones that occur after 20 weeks of gestation. So we figured with the inpatient population, they'd be coming in later on in pregnancy and for more severe complications, versus those coming in an outpatient status would just be coming in for routine prenatal visits.
Okay, that makes sense. And again, my favorite question, if you had a whole year to work on this, how would you like to expand this? What would you like to do beyond what you're you have planned right now?
That's a great question. I think besides just doing a retrospective chart review, it'd be nice if we were able to conduct our own transthoracic echocardiograms. That way we'd be able to choose exactly what parameters we wanted to look at rather than being limited by what is actually included on each of those reports. And it'd be a lot easier to standardize when those echoes were conducted.
Are there other questions? Well, if not, I think this will conclude this program. I think I'd like to congratulate all of the students for a job really well done. You've all, really made a commitment to research through this summer. I'm hoping that this will not be the end of your research. It will be only the beginning. And you won't be just doing it while you're a medical student or a resident or a fellow, but that you'll be doing it for the rest of your careers, because research is an essential part of being a good physician. It trains you to ask questions, to think outside the box. It's also very exciting and fun. And as I tell students who've worked with me, when you're doing research, you're never bored, because every answer comes with two questions, at least two questions. And so it keeps you constantly challenged to think, not only what do I know right now, but what's different about this patient, what's different about this disorder, and how can I make it better? And that's what this is all about. So thank you again. I really enjoyed all of the presentations that all of you have given tonight. Anyone else have anything they'd like to say?
Just echoing a great thank you for the students, a job well done, as well as our donors as well. And we thank you everyone for your attention.
Thank you.
Thanks. Good night.
Good night, all.
Thank you.
Thank you. Good night.